Yes, sir.
and go for it. We are recording, if that's okay with you. We like to
That's
we put it.
perfectly fine. Let me share my screen there.
I will say that what many of you do fits very well with what Joe's going to tell you about. So that's exciting.
I take it you can see my screen.
I see Zoom.
Says Zoom.
Yep, that's about right. Let me. It's okay. All right. Well, first of all, hello everybody, and I'm with you, Dr. Clearfield, in that what used to be considered quack medicine is now the standard. And you think about so many things in the history of medicine that were considered outside the box and now are standard treatment. And so also I have a son-in-law who served in Iraq, who's a paratrooper and bears a lot of physical scars from he had 32 jumps. And he said two of them went well. So I know, and he's got a little bit of in his left ear, has a little bit of issues hearing. So I don't know if it was Joel or the other gentleman that talked about providing better care to our VA veterans. It
Yeah.
is shameful that we have not
Yeah.
got that, but I know that's not what
We have
we're
a
on
lot of
here about. So
military. We have a lot of military people on here too. So
good, good. And well, I appreciate the opportunity. And my goal is to be 25 minutes or less. I will open it up to questions. I'll ask if you could to hold the questions till the end, unless it's something pertinent to what we're discussing there, because most of the stuff that you're going to think about asking is stuff that we've covered and are going to cover. But as Ron mentioned, my name is Joe Torres. I'm the VP of Sales and Business Development. I have our company has been offering the CMAT for 13 years. The CMAT has been around for 15 years. I've been with a company for 10 years. And all I do pretty much is the CMAT day in and day out. And so I'm a little familiar with it there. And but this is a great tool for what you are doing, particularly in the integrative medicine, where you're trying to bring some of the holistic homeopath into modern medicine, if you would. And so with that being said, I'll go ahead and get started. Normally, I ask a little bit about the practice, but Dr. Clearfield, you did a good job of helping us understand. I always try to begin with this with us, and that is that we were founded on the clinical side, on the CMAT side. We were founded back in 2000 by Don Wright, and for the last 24 years, we have been helping independent physicians, clinicians, chiropractors that have wanted to become integrative in their practice with not only patient but also business solutions, bringing things that would make tools that would help them provide better care. Something that is unique about us is that we actually, on our division, we own and operate our own clinics. For the first 17 years of our existence, we sold medical devices and services. I'm sure all of you have had presentations or have been approached by all sorts of different devices and services, and we were one of the leading ancillary companies. In 2018, we had the idea. This came from sometimes the best successes come out of failures. I don't know if any of you got involved into the allergy treatments, which in theory, great treatment, great idea, great application, but the documentation to get reimbursed and to establish clinical necessity was a virtual nightmare. We had no idea that it was that much work. And so we had a physician named Dr. Agarwal who had bought several CMATs from us and who we became close to. And so we kind of asked, hey, how do we beta test things before we offer them or sell them? And so Dr. Agarwal said, you guys need to start your own clinic in Georgia. You don't have to be a physician to own a clinic. You do have to have a medical director and things like that. There are some rules, at least for us. And so we partnered with Dr. Agarwal initially just as we wanted to be able to test some of the things that we were offering. And we realized that we were actually pretty good at running clinics, had never done it before. And so as you can see there, we opened up 3 during the pandemic, opened up a 4th one shortly thereafter, and actually are on our 5th one that we have. And so when we did that, it gave us a unique perspective in what we offer, particularly with the CMAT. The CMAT isn't just something that we're going to offer as a manufacturer distributor. The CMAT is something that we do ourselves. And so in 2018, it gave us a unique perspective to be able to have our own physicians, our own nurse practitioners, our own clinicians that really helped us understand how does the CMAT help provide better patient care. And so it gives us a unique perspective. And then also the practical benefits, something we did not understand. And those of you that are clinicians, I used to not understand why a nurse practitioner or doctor couldn't give me 2 minutes to tell about our services until we opened up our own clinic and realized that how busy the life is for clinicians. But we have become experts at integrating the CMAT into a practice without affecting the bandwidth of the office. Ultimately, we understand that the clinicians are the key to patient outcomes. But the reality is it's the staff, it's the nurse, it's the MAs, it's the office manager, it's the front staff that really drive any service or any device to be successful. And so the CMAT is something that can be integrated into the office without really any major effects to the office. You'll see that here in just a little bit. And then finally, the financial benefits. The CMAT is something that we bill for ourselves on a regular basis. And so we understand the financial benefits and how it reimburses. The CMAT is something that we do bill for on a regular basis. So we know what Medicare and Humana, and we know what all the other carriers require. And so we simply pass along what we know to be best practices with billing. But I want to start with what I typically do. And this is something that one of our physicians helped me as we were looking at how do we present this information. This is a document that we used to present after a post-sale. Once they purchased the CMAT or added the CMAT, we would use this. All right, here's how you bill. One of our physicians said, hey, Joe, this would really help a clinician in the beginning because it establishes the LCD to what you're doing. And so all of you, most of you would know what the LCD is, local coverage determination, started by Medicare. And as you know, everybody follows it if you're doing billing. There is a cash component to this that I'll talk about here in just a little bit for those of you that are chiropractors that are not necessarily using insurance if you're on there. So we do have some of those. We actually have one that uses it very effectively, but I'll talk about that here in just a little bit. But this is not my document. This is from the Medicare website. You could pull this up yourself and look at it for yourself. But the LCD, local coverage determination, establishes the roadmap, the rules of engagement of any type of coding or billing when it comes to autonomic function, really dysfunction testing. This is no different from whether you're doing an office visit all the way down to brain surgery. There's an LCD that gives local coverage determination. And so something that's unique about the CMAT device itself is that there's no such test as a CMAT. So for example, if you called Medicare, Humana, Aetna, Blue Cross, or whoever and said, hey, we just added a CMAT to our practice, so they would say, congratulations on the CMAT. And then they would say, number two, what in the world's a CMAT? What the CMAT does is the CMAT does a series of testing in autonomic dysfunction that have existed even before the CMAT was ever created. So these are the 3 CPT codes. There is one with a tilt table, but that's not required. But if you have one, it does add a little bit of extra revenue. But these are the 3 codes that the CMAT does. By the way, these are all evaluations and CPT codes that any clinician could and should do, and you do not need the CMAT to do these. The challenge is that it would take an average clinician about 45 minutes to an hour to do these 3 evaluations. The first one is an assessment of the autonomic nervous system, looking at that parasympathetic activity. It is out of this marker that we can identify things like insulin resistance. We can identify things like syncope. We can identify cardiovagal nerve dysfunction and other markers. Some of these are markers that are early detectable markers of diabetes, which I'll talk about here in just a little bit. And then also you have the second one here that is more of a vascular assessment, looking at the blood flow, which are things that you can detect like cardiac autonomic neuropathy, arterial stiffness, blood clots, and things like that are used with this assessment. And then the third one is assessing peripheral neuropathy. Now, with the space that you are in, for what I've done a little bit of research there, you deal with a lot of pain. Whether you're a chiropractor all the way down to a nurse practitioner or a physician, everyone deals with some type of pain. And so the assessment of peripheral neuropathy is a code that exists that any physician clinician could do. As I mentioned, though, if you go in the LCD, it shows you exactly how to manually do this first one of those there that you could do on your own. That again, if you look at all the information that is here and you realize, my goodness, if I had to put all this together, I'd have to write a report and be able to establish clinical necessity and know how to do this. No clinician is going to take the time to do that, no matter how effective it is, just because of the sake of time. For those codes, there's reimbursable CPTs that come with that. We'll talk about that here in just a little bit. But in the LCD also comes the diagnostic codes, the ICD-10 codes that go with it. So in other words, Medicare laid out the roadmap and said, all right, if you're doing these autonomic function or dysfunction codes, then these are the type of ICD-10 codes that you can do. Now, I'll stop here for diabetes because I have learned that it doesn't matter whether you are a brain surgeon, a nurse practitioner, a family practitioner, an internal physician. Everyone sees patients with diabetes. You may not be treating the diabetes in your specialty, but my goodness, you do see diabetic patients. Anyone that's been diagnosed with type 2 diabetes 100% meets clinical necessity across the board. But there are other ICD-10 codes that are there. This does not include the vascular codes, as our CMAT has an ABI built into it. So there are plenty of codes. So also in the LCD is the roadmap. And so these codes or these tests, according to the LCD, which, as you know, all the commercial insurances follow, there's some rules of engagement. Obviously, you have to have some type of a report, some type of interpretation. You need supportive documentation to establish reasonable clinical necessity. In other words, you can't just randomly order the CMAT test for anyone and everyone that you see. There has to be signs and symptoms of autonomic dysfunction, which we'll talk about that here in just a little bit. You have to have a medical history, physical examination, things that you're doing anyways. Also, they tell you you can use an FDA cleared device on these as well. Then it gives you okay, this is how you're going to use these codes that you've just seen. Again, remember, there's no terminology here for CMAT. The CMAT just allows you to do this in a quicker way. So these assessments can be used, first of all, as you see there, to confirm or exclude autonomic disease. Obviously, diabetes being a big one, but other chronic metabolic diseases fall into that. For patients that already have a diagnosis, so number one, it's a tool to provide information to reach a quicker diagnosis. But then for those that already have been diagnosed with some type of autonomic disorder, repeat testing is governed by a change of clinical status, response, therapeutic intervention. In other words, if there's a change of medication, new symptoms, new diagnosis, progression, regression are all reasons why you can re-administer the CMAT test. And again, the reimbursements are pretty substantial. These are the three codes that you saw there in the LCD. This one here, the vascular one, because our CMAT does lower and upper extremities, you're able to double bill this with a 76 modifier. But again, I'm not trying to jump too deep into the billing side of it. Again, there we reference. This is not our document. All we did was copy and paste out of CMS and out of the LCD. And so the CMAT is a 7-minute non-invasive risk assessment test. This is what the CMAT looks like. It's about the size of a ream of paper. Now, you guys look mature like me. I said that the other day to somebody, and they said, "What ream of paper? What do you mean?" So I thought, okay, you're gone paperless. But it's about 8 inches by 10 inches. It's about 2 inches tall. There are 4 blood pressure cuffs that come with it. Pulse ox that goes on the finger, laptop, leads that go on the bottom of the feet. The reason I share this with you is because this does not require a large footprint space. In other words, you don't need a large area. This will fit on any medical cart in any patient room in your office. But although it is small in size, the impact of the CMAT is huge. And so CMAT stands for Cardio Metabolic Assessment Test. It's an FDA approved. We do have our 510K approval. Actually, we have 6 markers that have all received their 510K approval. But 7-minute non-invasive. Anyone in your office can conduct the testing, so you don't need a registered nurse or a nurse practitioner or a PA. At our office here in Athens, Georgia, our practice manager's son, who used to be a student at UGA, would come in after classes, and he did all our CMAT testing. It's got great clinical outcomes, which you'll see here in just a little bit. It is covered by Medicare and all your commercial insurances, and it reimburses about $400 per test. And as you saw in the LCD, you can do repeat testing. But what the CMAT focuses on, when you think about who meets clinical necessity, well, if I took a peek in your waiting room, and again, it wouldn't matter if you are a brain surgeon or a chiropractor, nurse practitioner, primary care, I would imagine that there are people sitting in your waiting room that are hypertensive, diabetic, overweight, people with peripheral neuropathy. The statistics say that about 65% of everyone over 50 has some type of peripheral neuropathy. They may not be complaining of it, but they have it in a doctor's room. Anyone with cardiovascular risk, that's anyone that's a history of heart disease, smoker, drinker, sleep apnea. You probably know the markers or the qualifications better than I do. Anyone with osteoarthritis or joint pain because of the inflammation that is left behind, all of those would meet clinical necessity. Conservatively, we say that about 70 to 80% of everyone that's in a clinician's waiting room meets clinical necessity. Now, if you're a specialty, like you specialize in pain, or you're internal, or you're a neurologist, cardiologist, or something like that, that number goes higher. If you're more primary urgent care, that's more in that 70 to 80% there. Also, your area has an effect. If you are in a more rural area, in a more economically challenged area, those numbers, those statistics are higher there for you. So what the CMAT does, when you think about the numbers of diabetes, now the CMAT is not designed for diabetes, but I think all of us would agree that diabetes is so rampant, it's an easy disease to target because I think it's a large population. You've seen the statistics, so I won't bore you with all of those. It's not the 34 million Americans that, or the 10% of our population that has diabetes. They already know they're being treated. But if it's the other 84% of that 88 million that are unaware they are diabetic or even pre-diabetic. In other words, what that means is that the symptoms for that individual are not substantial enough or they have mentioned anything to their physician. What the CMAT does is the CMAT provides a solution to the challenge. And so this is something that I saw at a medical conference. A physician was doing a talk on preventative care. And I thought, man, this is, I mean, it was so good that I thought I'm going to steal it and take credit for it. But the physician said, this is how we practice medicine. He said, this is not reflective of physicians, clinicians. It's not reflective of the healthcare system. It's more reflective of patients. If you guys have been in practice for some time, you know, typically patients wait till they get to this point before they come see their physician. Not all of them, but the majority of them. I think any of us, if we notice the tires of our car look this bad, we would try to, number one, prevent the catastrophic event. We don't want the blowout of the tire, right? Or number two, we would say, is there any way to extend the life expectancy of the tire? I want to get another 5,000 to 10,000 miles out of it as possible. The truth of the matter is this tire is too far gone. And not that our patients are ever too far gone, but sometimes it's very late in the game. Whereas this tire did not happen overnight. This tire at one point had treads. There's a difference between a tire looking this way that has 40,000 miles on it versus a tire looking this way that has 140,000 miles on it, because one would make sense and one does not. And so what this does, the CMAT allows you as clinicians a tool, as you saw in the LCD, as an early detection for autonomic disease. So the CMAT provides a more complete solution to the traditional office visit. And it's not that clinicians or physicians are not qualified or able to identify, but really we rely, and I'm not a clinician, but we rely on patients. I was in Texas last week, and the patient had some of the early markers of diabetes, and I was telling, I'll talk about him here in just a little bit, but I was telling the physician who was being trained, I said, is this guy diabetic? And the doctor said, I don't think so. And he looked at his chart and saw, no, he's never been tested for diabetes. And I said, Doc, he's got, according to the CMAT, he's got many of the early markers of someone who'd have diabetes. I would bet my house he's a diabetic. And the doctor began to ask him questions. Have you noticed, any excessive thirst? And he said, now you realize it. I take my wife's big jug of water. He said, I never used to drink that. He said, I just seemed like I could never get enough. And he began to ask him about blurred vision and a few other things. And the doctor kind of inquisitive said, you know what? We may want to check you out for diabetes. Well, the reality is that patient had not complained of symptoms, even though he'd been seeing that doctor for something for a couple of years already, had not complained of those symptoms. So the CMAT in that way, particularly with diabetes, and again, this CMAT is not specific to diabetes, it's just because it's so rampant, we kind of focus on it. But for example, the CMAT can detect insulin resistance up to 8 years before the patient has diabetic symptoms. Typically, when I'm doing medical conferences, I'll ask the physicians, okay, guys, give me the signs and symptoms, the early signs and symptoms of diabetes, and I get the same responses: excessive thirst, blurred vision, exercise intolerance. You probably know the other markers, high cholesterol, things like that. And I'll say, when a patient has most or all of those, what do? Oh, we order an HB1AC to see if they're a diabetic. And I say, are you ever surprised that they're a diabetic? And they say, no. The reality is you really didn't need the test. You kind of already knew. The test just allowed you the formality of being able to diagnose and bill to treat the patient, right? Diabetes is not an overnight disease. Diabetes is a consequence of insulin resistance, which is a consequence of poor lifestyle, diet, exercise, and a little bit of genetics there. But think about, for all of the patients you see, if you had the ability to detect insulin resistance in its beginning stages, what that would do. You see, there's a window of opportunity for that patient that, if you can catch them before they're even pre-diabetic, is the biggest effect we can have on that patient. Now, not every patient's going to comply. Not everyone's going to listen to what you say, but it is a lot easier to try to encourage them to change diet and exercise because you see the early markers versus putting them on metformin, or on insulin the rest of their life. And so the CMAT can do that. The CMAT does the same thing with other chronic metabolic disease, and that it can track the progression or regression of that disease or that complication. The CMAT can also differentiate between vascular and neurological peripheral neuropathy. When I do medical conferences, I'll ask the physicians, hey, I'm 49 years old, hypothetically. If I came and said, hey, doc, I have numbness, tingling, burning sensation in my feet when I wake up in the morning, it feels like I'm walking on glass, what would you tell me I have? And they all say, well, you probably have peripheral neuropathy. But as a patient, if I said, okay, doctor, I know this is the first time meeting, and thank you for telling me I have peripheral neuropathy, but could you tell me if that neuropathy is vascular or neurological? Could you determine or answer for me in that moment which one it would be? And most of them say, well, not right away. Over time, we can tease out. Then my next question is, well, how do you tease it out? Well, one is either you look at history or other factors that will determine or help you determine. But most of what I hear from physicians is we would treat it based upon what we think it is. Maybe we would prescribe gabapentin or something like that to see the effects of it. And then if that doesn't work, we realize, okay, it's maybe something else. Imagine being able, with all your patients that come in with lower extremity pain, to be able to instantly determine if it's vascular or neurological neuropathy, or if it's a little bit of both. Because although the symptoms may mimic each other, the cause is different, but the treatment is also going to be very, very different. And then also, it allows you not to depend on just the patient telling you how they feel. You can have a distinguished marker to know if there's progression or regression. The CMAT, in the same way, is a tool for early detection of a stroke, heart attack, blood clots, and other vascular issues. Again, same thing with diabetes. Outside of the actual catastrophic event, if I ask physicians or clinicians, hey, what are the early signs of a stroke or heart attack besides the actual catastrophic event, I get the same responses: sweat abnormalities, shortness of breath, exercise intolerance, change of skin tone, and on it goes. Irregular heartbeat. I'll say, well, typically when a patient has all that, what do? Well, I send them to a cardiologist. Well, then the cardiologist does a series of tests, and we find out, hey, they had a 70, 80% blockage, and we went ahead and either treated it with medications or procedure. That's great. Well, what about when they had 50% blockage, 30% blockage, 10%, 5% blockage? Wouldn't it have been better for that patient, as far as an outcome, to be able to catch it when it was at 5% versus at 50 or 60%? The CMAT has the ability to detect arterial stiffness, the plaque buildup in the arteries, at its very beginning stages. But it even goes one step further than that. The CMAT can also detect endothelial dysfunction, which is, is the inability of the blood vessels to expand and contract, which is asymptomatic, but then also it is reversible without medications or procedures. If you can catch that patient at that window of opportunity that transition from endothelial dysfunction before they get arterial stiffness or early, I mean, that's huge outcomes for a patient. Also, if you've been practicing medicine long enough, you've had that patient that you've been seeing for a while, and you're surprised that they had a stroke or a heart attack. And, God forbid, maybe it was fatal to that patient. And how did you not know? Well, it wasn't because you weren't looking. It's because the patient maybe didn't bring it to your attention, particularly when it comes to things like cardiac autonomic neuropathy, which isn't always symptomatic. And so the CMAT can detect all of that and do so much more in a 7 to 10 minute test. And so the CMAT provides a great clinical output for you as clinicians, and that it looks at the vascular movement, or the vascular movement, blood flow in the patient. It looks at small fiber neuropathy versus microcirculation disorders. It looks at cardiac autonomic neuropathy. It looks at the neurological function of the heart and other organs, and then it also looks at peripheral artery disease. So, for example, the CMAT is not and never going to pinpoint where the blood clot is, but it'll tell you that based upon the calcification or the claudation, that hey, there's enough restriction of blood flow, they may need to have other testing as well. So the reason why the CMAT is so popular among clinicians and many of our physicians and nurse practitioners and integrated practices that have that is because oftentimes, as you know, those symptoms mimic each other. And eventually you'll be able to tease out if you're a good clinician and be able to treat it and have a course of plan. But oftentimes things like diabetes, kidney disease, hepatitis, thyroid, or aging, they mimic each other. So being able to differentiate, are the issues more vascular or neurological, is a huge tool for a physician, a clinician, to make better decisions. The CMAT is not going to diagnose. It's not what it's rated for. It's rated as a risk assessment, not as a diagnostic device. But really what the CMAT does is it provides you a complete evaluation of both their vascular and their neurological treads of the tire, if you would, to be able to help you make better decisions. The application is very simple. There's no fasting. There's no prepping. The hardest thing the patient does is remove their shoes and socks. There are 4 blood pressure cuffs that are placed on the extremities, a pulse ox on the finger, leads on the bottom of the feet. The test itself takes 7 minutes and 48 seconds. By the time you explain it to the patient and they take their shoes and socks off, it's about 10 minutes or so from start to finish. But in that 10 minutes or so, the information that the CMAT provides is remarkable. I will say this at this point. There is a secondary, what we call a deep dive. I've learned that to try to cram everything into 25, 30 minutes is virtually impossible. And so I'm just giving you a 20,000-foot view. If you're interested, there's a deep dive where I go into the actual science behind the markers and how Dr. Merrick, who's a neurologist and the inventor and patent holder of these markers, what he discovered. But probably the biggest and simplest way to explain it has to come to the cardiometabolic score. This score is based upon 40% is a neurological assessment, 40% is a vascular assessment, and the other 20% is it's really a homeostasis score. The FDA did not allow us to use that term. So they did allow us to use lifestyle score, which doesn't make sense to me, but that's what that is. And so for the first time as a clinician, besides just having to depend on what the patient tells you, you will have a baseline of where that patient is today. And as you are treating that patient, whether it's with homeopathic remedies, whether it's with weight loss, exercise, counseling, or pharmacological medications or treatments, you're going to be able to see that patient is either progressing or regressing. Also, the CMAT, we've tried to design it. This came a lot from us owning our own clinics, where we were able to ask our physicians, hey, what would help you? Because the data is great, but the reality is as many patients and as busy as clinicians are, they don't always have time to look at all the numbers. So we've set it up so that green is good, yellow is borderline, orange is bad. Pretty simple, right? And so at a glance, you can see where that patient is. We've also created a summary that gives you a description of what those markers mean and what you may look for. For example, the CMAT is never going to say, this patient is a diabetic. The CMAT will say, hey, you may need to look at testing for potentially diabetes, renal disease, kidney disease, or other things that it's going to look at. And so there are 6 funnels that the CMAT is actually measuring. These are the 6 patents and 510K approvals that we have. This is one of those. Because this is the the easiest one for everyone to understand. And so this is a risk of a stroke or heart attack. So these are the markers that the CMAT is measuring, things like C-reactive protein, heart artery blood flow, small artery stiffness, vascular tone, insulin resistance. So this is an individual that's 54 years old. This is actually one of our salespeople. And this gentleman is in the Tampa, Florida area. And he is 5'8", 256. Now, Bobby was a former football player and a bodybuilder. So although he's overweight, he's very stocky. He's very muscular. And we were doing some training in an office, and we were waiting on a patient to come in. The patient was running behind. And the doctor says, "Hey guys, I'm in a hurry. Can we just test one of you?" And I said, "Sure. I've tested myself a gazillion times. I can tell you what it's going to say." And Bobby made the comment. He said, "Well, if you want to test me, you can, Joe." He said, "But I'm not sure if I'm a good candidate." And I hope I communicate this correctly, because this is the part of the CMAT that really has the most effects. He said, "I'm not sure if I'm a good candidate." He said, "I'm not a diabetic. I don't have a history of diabetes." He said, "Nor do I have a history of strokes or heart attacks." He said, "We do have quite a bit of cancer in my family, but luckily I don't have those things." And he said, "I just did my annual wellness visit with my doctor, and other than quit drinking so much coffee and losing maybe 20 pounds, he said I was pretty good to go." But I want you to notice here where my cursor's moving, you see the insulin resistance. Well, the numbers show that anyone below 406 with insulin resistance has normal insulin resistance. Anyone between 406 and 550 has or borderline, and that accounts for maybe what they ate, different functions that may give you that range of what is borderline. But anyone that is over 550, I would bet my house, Bobby was a 586. I would bet my house that Bobby was a diabetic. I've yet to see anyone that's over 550 that isn't a diabetic. Now, if it's not a certainty, well, it's a very, very high probability. And then it adds all these other markers, and it brings you to our risk chart, which shows the risk of a stroke or heart attack. So if you see where my cursor is moving here at the bottom, when you go from type 4 to type 5, on this end of type 4, they have endothelial dysfunction. That's the inability of the blood vessels to expand and contract. When they cross over to this side, now they have the beginning of the plaque buildup. So now they have arterial stiffness. Well, you can see where Bobby was. So long story short, the doctor says, well, and I said it just like that. I said, "Doc, Bobby, I'd be surprised if you're not a diabetic." Bobby ended up going back to his primary care, was tested for diabetes, and sure enough, he was a diabetic. But the other thing, because he had such substantial arterial stiffness, the CMAT said he may need to see a cardiologist. And so they found an 87% blockage in his left ventricle. And so Bobby was 54 years old. When would he have gone to his physician to complain of the signs and symptoms if he didn't have the heart attack or stroke on his own? Maybe when he was 58, 59. And by then, that window of opportunity was huge for Bobby to make a difference. And that's how the CMAT does that with other risk factors that a physician or clinician can use. And then it provides you, as I mentioned, the summary. I'll just draw a couple things to you. So for example, here with this patient, it says the absence of pseudomotor response in both feet, refer to a neurologist. So in other words, Bobby started mentioning that he did have some tingling, some burning sensation in his feet. He just thought it was because of all the years of football. The reality is he was losing some of his neurological function in his feet. And so sometimes it'll tell you, hey, refer them to a cardiologist. Sometimes it'll say, hey, we look envisioning maybe geriatric surgery, or hey, they need to see an internal physician, or they may need to see have a blood work done for diabetes. It will give you some suggestions on what you may want to look at. So really what it does is it takes you from reactive medicine to proactive medicine. It allows you to stay on the vascular and neurological treads, if you would, of that patient to be able to provide better care. The reality is, and you guys know this more than I do, we need patient participation for a better outcome. The medications and the treatment and the surgery only does so much. If that patient doesn't participate in their overall, if they don't make some changes, even if it's just, hey, I'm going to lose 10 pounds, or I'm smoking 2 packs of cigarettes, I'm going to go to 10 cigarettes a day, or I'm going to cut out the soda, or whatever it is. Those little things can have big long-term effects on a good majority of patients. Well, now you have the ability to show the patient where they are and be able to encourage them to make those decisions. of all the things we hear, so when someone adds a CMAT to their practice, we typically 3 months in will follow up and ask, how's it going? Do you have any questions? And we always ask, what is the biggest impact to you? Well, the first thing we hear is the revenue. This is about 90% of the time we hear the revenue is outstanding. Then we'll say, okay, besides the revenue, what is the biggest impact to you? And I hear this probably more than anything else. I hear it over and over, and they say, by far, this is the best coaching tool I've ever had. Because for the first time, I can show the patient where they are. And for me as a clinician, I can confirm that, hey, what we're doing is actually working. Every specialty is going to use it a little differently. These are the 6 funnels and the 6 patents and the 6 510Ks that we have. And these are the evaluations, but every specialty is going to use it differently. Pain is and neurology is going to use it differently than cardiology, different than endocrinology, different than internal medicine, different than maybe an integrated practice, maybe different than if you're doing physical therapy, wound care, things like that. But it's the same evaluation just for your specialty. And so when you think about who meets clinical necessity, well, anyone with these diagnoses meet clinical necessity, or anyone with these signs or symptoms, if they've not been diagnosed, meet clinical necessity. Remember what it said in the LCD. You can use it to exclude or confirm autonomic disease. And so when you think about of your patient population, of the patients you've seen today, how many of those that you've seen today would have these conditions or symptoms? I would say probably well over 70 to 75% of those. The reimbursements, as I mentioned, are pretty substantial. I did want to show you, though, just because the reimbursements is the part that people typically want to see. And so I wanted to give you some actual real so this is, again, looking at the LCD. This is the typical reimbursement there. By the way, this is another more, if you add the CMAT, we actually show a more in-depth signs or symptoms. This establishes your clinical necessity. But there, hopefully you can see this. I'll make this a little bit bigger. But these are the reimbursements that we see. This is from New York, which New York is one of the hardest places. I don't know if we have anyone from New York here, but New York is very hard to adjudicate ancillary services. It just is. And so, but I want you to see also the deductibles, the copays. I'll show you some good ones and bad ones. I'm not going to show you all winners. But on this one here, you can see that it reimbursed $350 per patient. United Healthcare. And so you can see here, there at the bottom, there it reimbursed $405, and there you see our 3 CPT codes. Also, you can do these with an office visit independently. There's Cigna. You can see here, Cigna only paid $63. That was a billing issue that they did there. Here's one on Blue Cross Blue Shield that paid $496. This is MVP. If you're taking any of those newer insurances like Oscar or Empire, these are actually right now reimbursing really, really well because they want physicians to take them on. And so right now they're really popular, but there you can see the 3 CPT codes and how they reimburse. This is Horizon Blue. And so there you can see that one. Oh, you have to add all those 3 together there, but 60, 28, 60, 70. And then here is a Empire that paid $418. And this is one that's a nurse practitioner. I know we have nurse practitioners on the call. And so as you know, nurse practitioners, depending on state to state, make about 85 cents on the dollar. So these are you can see her report, Performa. And then, so this represents 1 month. And so they had 29 tests at an average of $310 per test is what they averaged on the CMAT. Here's a nice one that came in. Actually, this one was sent to me by another nurse practitioner out of Kansas City. And you can see there, it's interesting. These codes are not our codes. Those are, I think that's an office visit. You can see she didn't get, the provider got nothing. Where her money came on that day, it came from the CMAT. So she sent this to me saying, what do I do with this? And I say, enjoy it. So if she was like, did I do something wrong? No, you billed it correctly. It just reimbursed pretty well. And then, guys, I won't bore you with all the EOBs, but this reimburses pretty consistently there for you. And I've just got just a couple more slides, and then I'm done actually. So when you look at by the numbers, and obviously it comes down to whether you are a brain surgeon or a nurse practitioner, family, a provider, integrative chiropractor, everyone has the same expenses Some are greater, some are smaller. Everyone has mortgages, payrolls that are due, insurances, liabilities, all, water bills, all that stuff. So there is a financial side to this. So we know the average clinician sees between 20 to 25 patients a day. Some see more, some see less. Again, as you saw, we say that about 70% of those would meet clinical necessity. That would give you about 15. Now, we're not suggesting that all 15 of those be tested in a day. What we are suggesting is it would make sense that about 10, maybe 20% of those, it would make sense to be tested. It's up to the clinician to determine that. Some of that we provide in the clinical training, but that's about 1 to 2 a day. The average reimbursement, as you saw, is about $400, maybe 20 bucks more, maybe 20 bucks less, but in that ballpark. So if you think about just on the lowest, I try to give like the lowest part, because then you guys, if you have more providers or a busier office, you can extrapolate the numbers from there. But if you're doing about 20 a month, and I don't have a single practice that does less than 20, and I've got a 74-year-old primary care physician in South Carolina that is open 2 days a week, and he does 21, 22 a month. But at $400 a test, that's about $8,000 a month in revenue and about $96,000 annually. Now, I don't know where you are at financially, nor am I asking, but what I've learned in this business is for a lot of our independent clinicians, that's a game changer for them. I mean, it is life-changing. It's the difference of them being able to keep staff. Recently, we had a physician in Nashville who bought a CMAT from us. We shipped it to him. We were trying to reach out to him to get it installed and trained, and he wouldn't return our emails or calls. We finally got a hold of him. He said that the day the CMAT was delivered, my office manager told me she was interviewing at the hospital, and I don't know what I'm going to do. And so this is the last thing on my list. And I said, well, why is she going to the hospital? I already knew the answer. They can offer her benefits, but they can offer her more money. I said, well, Doc, why don't you use the CMAT, that revenue, to keep if she's really that valuable? And he did. And so it was a game changer. Well, if you've got multiple providers, or you maybe see more patients, or a little more progressive, which a lot of the osteopathic, homeopathic integrated practices tend to be a little more aggressive or progressive, I guess is a better way. But if you're doing 3 tests a day, 60 tests a month, you're looking at about $25,000 in revenue and about $280,000 to $300,000 annually in revenue. Most of our offices are somewhere in between. I don't have anyone that does less than 90 grand a year. And, I have a few that are $500,000, $1 million, but those are ones with multiple providers there in the office. So hopefully, in conclusion, you see the clinical, the practical, the financial benefits of the CMAT. This is something that you see as, hey, this is something I think would benefit to me. So the next steps for you, if it's something that, whether you are looking at it from a broker, or you're looking at it for your own practice, would be to schedule a deep dive. And that I'll leave that to Jane and Ron to figure out how you guys would like to do that. But in the deep dive, I go a lot more specific into the clinical, a lot more into the billing, a lot more into the practical there that we have. And so my salespeople, the MSRP is 55 is what these go for. The pricing that Jane and Ron have are different because they're partners, because we deal in volume with them. That's what my sales rep would sell these individually to a physician, but that's not the pricing for you. But Ron and Jane will go over that with you guys. I'm happy to open it up to questions. I don't have anything else planned for tonight, but at the same time, I realize it's the end of the day for you guys. So Dr. Clearfield, if you've got any questions, or Jane, I'm happy to answer those.
I'm gonna leave it up to the group for now, and we'll pick it up in a few minutes there. Jane, would you have anything to add? Thank you so much, Joe.
You're very welcome.
That was wonderful, very comprehensive. So I do have a question for you, Joe. How does this work for someone that is not on any insurance policies?
Okay, I forgot to mention. So I have a chiropractor here in Georgia that used to be the chiropractor for the Atlanta Thrashers. He is in Buckhead. If you know Atlanta, you know where Buckhead is. It is a high-end type of a situation. So he charges about $200 for the test for cash. It's really up to what you believe your population is able to afford. If you're in a cash scenario, we sell some overseas. obviously the people we sell to overseas are in a higher end type of an area. But if you know that your patient population believes and follows in you, you can get anywhere between $100 to $200 per the test, and will probably use it more effectively than a lot of some of your practices that are just doing it for revenue, quite frankly. So that's how that works with chiropractic.
Joe, there's just a couple things real quick. Someone just asked, just typed in and asked about the cuff sizes, the multiple cuff sizes, wanted to know if there were
Yep.
different cuff sizes.
So these are rated for anyone up to 350 pounds. There is a large blood pressure cuff that goes with it. Again, we by the way, at our clinic, the one I'm involved with, we do between 75 to 80 CMAT tests. Over the last 3 years, we have probably used the large blood pressure cuff maybe 5 times total. Because we actually track it, because we don't ever think that they're big enough, but I think we've used it 5 times total in about 3 years, the larger ones.
Yeah. The other thing I wanted to mention to everybody is that don't let the price of the machine scare you, because it includes a lot of other things, all the training of the billers and the providers and the staff and the testers. But also we have a financing program that gives you 90 days to test and bill and collect. So you shouldn't have $1 out of pocket, and only 3 tests a month. And Joe mentioned he doesn't have anybody doing less than 20, only 3 tests a month pays for the machine. So we make it very easy for you financially.
And typically, if I could add on that, about 100 patients reimburses the entire cost of the device. And most of our providers within 6 months or less are hitting right at that 120 patient mark. As you saw, I think I showed you one with where the nurse practitioner did 29 in a month. And that's kind of her average, is about 20, then we're about 30 or so. So it would take her about 4 months to generate enough. And by the way, that's Karen, Ron, if you remember her. She is a single nurse, but she bought 3 units from us. She bought one and then realized what it could do for her, and actually hired other nurse practitioners to work in the retirement community, has opened up a couple clinics, and it's been a game changer for Karen.
Someone also asked about support initially, and support ongoing, really. Yeah, we provide all that training, all the support. Anything you need or questions you have, we want to help you succeed. It makes our business succeed, so we want to make you succeed. So
let me and I realize you leave things out when you're trying to stay brief. Part of what we do on our end, for those of you that are considering this, we don't put any of the work on you as far as with having to deal with implementing or installing or we do all that. The pandemic really helped us become really good at installs and making those easy to do. I do have the chat up now, Ron, so I can see those. I didn't have it on because I had my screen. So all the billing, the secret sauce in this, ladies and gentlemen, is the billing. And so we have an expert biller that's all he does. He bills for our clinics. He bills for others. He's been billing for the CMAT in fact, we met John through a physician we sold a CMAT to, and John saw like, what is this device that's doing all of this? And so we partner with him, but he does all the training on the billing to make sure that it's done. Someone had asked another question there, and my screen just changed.
I think that was Lisa.
Okay.
That was Lisa, Joe.
Yeah. So my screen changed. I don't know if I did something, if I hit something. Lisa, what was your question? I'm sorry. I saw, okay.
So go ahead. Lisa, do you want to ask it about chiropractors?
Lisa's microphone is off.
I'm sorry, here we go. I just wanted to be sure, it doesn't have to come from an MD. It could definitely come from a chiropractor.
No. The only thing is you're not able to bill insurance on those. But again, if the chiropractor has great connections with those are probably some of our better business-minded, progressive clinicians, our chiropractors who are really progressive in how they treat their patients, but it would be a cash thing. I mentioned earlier that the most I've seen is a couple hundred. Typically it's in that 100, 150, but if you're seeing a lot of patients, it could be a substantial revenue generator for you.
Joe, I have
And
a
the other thing it does, by the way, just if I could add one more thing for chiropractors, it really allows you to compete, and it allows you to compete with physicians and clinicians because it is a medical device that you're able to show, hey, we're by being able to relieve the back pain, the discomfort by making you more ambulatory, that stuff affects other aspects of their autonomic dysfunction or function. And so you're able to show them, hey, this is what we're doing is having an effect. And even in conjunction with their physician, it's not replacing, but it can work in conjunction with them. What other questions do we have?
So Joe, that was a great presentation. So I noticed that you also have the way to assess endothelial function.
Yes, sir.
And there's a device used by Dr. Mark Houston from the Hypertension Institute. I mean, it's not just by his facility, but he had done studies in terms of the accuracy of the endopath. So how do you compare the results of your machine to this machine, if ever there was a comparison?
So I've heard of the machine. I don't know what markers they use. And again, this is Jane. You'll have to direct me as to how much time you want to give me, because this is where we can get in the weeds, and this is where the deep dive actually, because that's such a great question,
I think we're good.
Melvin. But that's where in the deep dive presentation we go into the markers of the CMAT. I'll just show you real quickly.
Well, for the CMAT, you have other parameters that you're actually assessing. For this one,
Oh, definitely. Yes, sir,
really
definitely. And
function.
yes, sir. And so there are markers that we're using. So what we're doing is in essence, we're comparing a patient's behavior, a patient's regular algorithm of vascular function, pulse wave, heart rate variability, blood flow, and then we compare what a healthy patient should be versus what they are. And that's where we have that differential, shows us what is normal and abnormal there. And so that's what I go into in the deep dive. I kind of go specifically into that there for you to see, if that makes sense.
Yes, thank you.
How does this differ, Joe, than just the heart rate variability?
So it's not just the heart rate variability. So it's a series of other markers as well. So just doing heart rate variability is great, but if you're not looking at blood flow, if you're not looking at how the blood flows all the way down to the extremities from the finger all the way down to the bottom, you really don't get a complete vascular assessment. So for example, the CMAT not only just looks at heart rate variability, it's able to detect if there's cardiovagal inversion. It's able to detect if there's POTS, tachycardia, syncope, versus just the patient saying, hey, I'm dizzy when I stand up. Well, you have low blood sugar. Well, it could be that, but it could be something else as well. There are a lot of other markers that the CMAT is measuring to be able to provide those. And that's where the deep dive, and I'm just screening through, but that's where the deep dive goes into how we're able to pull that spectral analysis, that photoplasmography.
Is it a sort of like a layer type thing where you can do just part of one and then add, sort of make it a menu kind of thing, add the next part,
That's a great question. So you're always going to do all the tests, but you can choose on the report what you want to see.
Okay, well, why would you do that then? If you're going to do
Exactly.
them.
So the only ones, for example, and we don't do a lot of podiatry just because podiatrists, they can't bill above the knee, but they can sure look at that peripheral neuropathy.
Mhm.
And so for them, they don't need to look at if they have cardiac autonomic neuropathy, if they have, so they'll just on their reports, they'll just show the peripheral neuropathy section. But no, it wouldn't make sense not to do it all.
Mhm. Can you pull up a report again and kind of just go through it? Is that
Absolutely.
do?
Jane, do we have time for that? And again, I am on your guys' time, so I'm not.
Yep, we have time for
Okay.
that.
So this is a good one. Actually, I was doing a training for some physicians today, and this was such a great example. So this is a guy, this is the report actually. He's 6'4", 44 years old. He's not overweight at all. This gentleman had come to his doctor with pain in his right leg, right below his buttocks. He just had a little bit of stiffness. And he had just had the CMAT delivered. He said, I just had a patient come in the other, I don't know what's wrong with him yet, but he's in pretty good shape. And do you think he'd be good to bring back? And I said, sure, bring the guy back. And so when I saw him, I thought, okay, this guy is going to be in really good health. So this is the report. So you see the vascular assessment. Well, very quickly, if you look here, you can tell right away, green is good, yellow is borderline. You can see right away where the issue is on his
We're
ankle
not seeing
brachial
it, Joe.
index.
Yeah, we're seeing you, Joe. So
We're not
I'm
seeing
sorry.
it.
Forgive me.
Sorry to interrupt, but
No, I thank you for interrupting me. Can you see
There
there
now?
you go.
Okay. So if you see here on this patient, you can see here the issue for him on his score, 74 is not bad, but you can see, okay, there's a mild blockage there. You can also see on his sweat response, which is vascular dysfunction there. And so these are the markers, by the way, one of you that was asking, these are the different differentials that it's looking at on this particular patient. This is what the report looks like. So you can see, okay, where's the issue with this gentleman? Well, we can see here, his arm blood flow was correct, but on his right pulse wave velocity, so in other words, the way the blood was flowing to his extremity, he had calcification. But initially you would have thought, okay, maybe it's a blood clot, which is what we thought, but you can see there in his peripheral artery disease, it was calcified. And so as I'm showing this to the physician here, by the way, these are some of the other markers. And I know I'm going through this fast because I want to give you a 20,000-foot view. But it's in the summary that we see what was really the issue. So everything else was fine because, again, the guy was fairly healthy. He ate right. So, and I had never paid attention to this, but it said stiffness may be due to artery calcification, potential blood clot, right? Diabetes, kidney disorder. And the doctor said, kidney disorder. He said, I don't think I would have thought of that. Long story short, he ended up doing some other testing and found out that was actually the issue. Now, would that doctor have eventually figured it out? I'm sure he would have. But to be able on that day, be able to see something that he normally wouldn't have looked for, that's what the CMAT does. And then it allows you as that patient, okay, we've identified it's some type of kidney disorder. How do you treat that? Well, there's all sorts of different treatments depending on what it actually is, right? But then as that patient is being treated, that score, if there's improvement, is going to increase. It's going to get better. And so you'll be able to show the patient, hey, what we're doing is actually better. So this is the physician report or the clinician report. The patient report, we've simplified it because if you handed the patient that 8-page report, they wouldn't know what it is. So this is designed to help you as a clinician be able to show the patient, okay, you're a 74. Here's where the 74 range is, almost like your credit score. My wife is very big on her credit, and when it drops to 798, she's like, what caused it to drop? Well, it varies on whether you use your credit card or what have you. But it shows them where their issues were. But then also here, if you see, it shows a trend. So you would have test number 1, and they would either trend up or trend down. Also on their trend, because this is just one test, it would show where the markers are, where they improve. But then this also provides them a suggested wellness plan. Now, let me say this. No clinician is going to agree on everything that this says, but it does give the patient something that you can give them to show them. Because if they just made some just minimal modifications to their diet, would make a big difference. It shows what their ideal weight should be. I know that's subjective, or everyone has an opinion on that. It tells them how many calories they should consume. I know there's good calories, bad calories. It also tells them what type of exercise level. So I had a doctor that once called me and said, hey, Joe, I'm curious as to why it said no vigorous activity. And I said, well, does he have arterial stiffness, and does he have cardiac autonomic neuropathy? And the doctor looked and said, he actually does. I said, well, the reason why they don't want him to do vigorous activity is because it's a high potential for a stroke or heart attack. So it also gives suggestions of supplements. Again, I know not everyone agrees on the supplements. I understand that. but then it also personalizes the types of foods that they should eat. And these are customized to what their markers are. So somebody that's diabetic versus somebody who's got the markers of hypoglycemia versus somebody who's at risk of a stroke or heart attack, these are going to vary. Again, this allows you a tool to be able to provide that clinician or that patient rather, so that they can see. At our clinic, when they're in their car and they're coming out, I see them with, because my office sits right where the door is, up above it. Clinic is downstairs, and I see patients with this piece of paper walking in to have their test. We actually have to turn patients away because we can't just do the test just because. So, but they're often like, hey, can we have another one? And so we have to say we can do, and we're just not going to bill it there. That's really the win here. It really is. It's complex science. My goodness, it's just the simplicity of that cardiometabolic score. But that's the report.
Okay, it looks great. So
Joe, are there any studies already ran by your company on your machine?
So in this markers interpretation that we have, so when Dr. Merrick discovered the algorithm on the pulse wave velocity, he commissioned a study with the University of Miami. That's where this all started. And through several years, he put studies together and what have you. So we've put some of those studies there in this document. There's a hyperlink to the ones we felt like are more user-friendly, because we realized that no clinician was going to read all of these, but these are the studies that are there that confirms all of this there for the CMAT. And this is something that I can send Jane, and then Jane, you can get it to the team however you'd like to facilitate this to everybody.
Well, what I noticed from cardiovascular supplement companies, they actually kind of tie up with these vascular testing companies to actually assess their products. So maybe just an idea for you guys to assess like a nitric oxide product. And we in this in the webinar series that we do, there are people here who you probably can connect with and actually add more, I guess, use for your machine.
Sure. Absolutely. Absolutely.
Question, Joe? Do you
Yes,
guys,
sir.
you have a list on your website of doctors throughout America or people throughout America who have bought your product, and we can get the testing?
Yeah, it's something that we've kind of stayed away from.
That's very dangerous.
So I used to have I have letters that I could send you guys from doctors. The challenge I had was we got calls from doctors saying, please don't put my information out there. I just got another phone call from someone looking for, and so we do that with physicians that are interested in promoting that. But I have found that oftentimes that it creates more. And then also, if I could be transparent, who do you think I'm going to post? You think I'm going to put somebody on there who's going to say this thing is it's a snake oil, it doesn't work? Anybody that I would put is going to say wonderful things about the CMAT, and I'm probably going to write it for them. And so what we've tried to do is we've tried to say, let the device and the clinical information confirm what it does, versus having to have some marketing piece that and I'm being transparent with you. If you go to our website, you'll see some doctors' recommendations, but it's just, and that's kind of our philosophy, is we have a little bit of different approach to that.
Yeah, Joel, one thing, this is Ron. Joel, one thing that I found, if you look me up on Google, I've run 3 public companies in healthcare and had a couple thousand doctors working for me, and many of them are very good friends. And I've had some very good friends call me and say, listen, I'm not your salesman. Don't have people call me. And these are my friends. So, that's why I said that's landmines we're jumping on there.
Gotcha.
The other thing with those is it's human nature, right? If someone is calling somebody else and they haven't been through the presentation. So let me back up. I'm not saying we would never have another physician. If someone is at the point where they're ready to move forward and they're missing that one clinical, absolutely. I've got a Dr. Monica Bell, who's a world-renowned neurologist. She's a brilliant scientist. And I had a neurologist here in Georgia help me, because she didn't hear anything that I hadn't said. I'm not a physician, right? So there was a little bit of that, Joe, you sound smart, but you're not a doctor. She asked, "Where'd you go to school?" And I said, "Crown College of the Bible. I have a pastoral degree." She's like, so I had a doctor help me explain it to her in literally in 5 minutes. And so I reached out to her, not to us, all right, Dr. Bell, I need your help. I've got another Monica Bell. And so we're not opposed to that, but we'd rather use that physician on the back end when someone's done their due diligence versus, as Ron said, putting their information out there and having them take 1,000 calls and then they get mad at us.
Thank
Okay,
you.
I
If
have
that
a
makes sense.
question here. Okay, let
Yes,
me
sir.
ask a question. I'm Dr. Halasa here. I mean, your product is among other two that I know. It's LD Tech, Medea, and
Yep.
there's one in Korea, and there's
Yep.
some of them from Russia. How
Yep.
you think that your product is better than them?
That's such a great
Price-wise,
question.
efficacy-wise.
Yeah, that's such a great. The difference with us is we opened up our own. So I know the people. I know the Medea. I know Joe with Medea pretty well. I know Dan at LD Tech pretty well.
Yeah, I know them all. I know all
Yeah.
those companies. Yes.
Yeah, yeah, and they're
I
good
used to
people.
promote your products as well.
Yeah,
And my
they're
network.
good people, but they don't own their own clinics, and that's where when we created our reports are created based upon what we've learned from our own clinics. Secondly, and this is the big thing, and I'm not big on dumping on other organizations because I would appreciate them not dumping on me. The billing part. I know with Medea and LD that they provide no. If you go to their websites, they just have the 3 CPT codes. They're not going to provide you the expertise on how to bill for this correctly. And with a lot of those, you have to figure out how to bill. And so where we're different is we bill for this ourselves. And so we're able to show you, hey, this is how we know to bill. And then the tech support is the other thing where we would separate ourselves and that we have our own internal tech support. And so it's almost like getting a cell phone, right? You can buy the Apple, you can buy the iPhone, you can buy the Android, Samsung, or you can buy the Google phone. I think the Apple phone is the best of all three, but they all make the same phone calls. It's just there's different benefits, and that's what separates us. That we own our own clinics.
So you have better services than them, but the equipments and the logarithm is the same, right?
Well, no, the difference is our reports are a little different. They're easier, they're more user friendly, and then the training is a little bit better with those. If I could be, we almost sold the Medea product back in 2017. We reviewed it, loved it. If you know it, it takes about 30 minutes to do. They
Right.
need to put the leads on the torso, and that just made it where you're adding a 30-minute test to a physician, a practice office. It just wasn't practical for us. And so they're good products. We just feel like, and maybe I'm a little biased, but I know what the CMAT does, and it's more than just the device itself. It's all the back end stuff.
Can you
Yeah,
place the
and time
product?
is money. Time is money. 7 minutes versus 30 minutes. Time is money. That's all doctors have is time. And I've had many doctors who work for me that said, basically they're doing piecework. They get paid for every patient, every procedure they do. They need the time. And so 30 minutes versus 7 minutes is a huge difference. Also, if you're just billing the codes, I've seen people get about $200 instead of $400 because they're not billing it right and they're not utilizing the ICD-10 codes properly. So those are really what differentiates us.
Can
Now,
you place the product for, like, let's say, because I used to work with this thing. Can you place the product in the clinic and the clinician will say, you have a tech, bring your tech, do these things, and I have my patients lining up, right? Let's say minimum of 15 patients, and then bill it, throw me, and then we split, or I don't know how the arrangement will.
Yeah, I can answer that. So there's not a lot of people doing that anymore.
Okay.
It's something considered code steering. The issue is with clinical necessity. Only a physician or the clinician can order the test. And so where a lot of those companies got in trouble. But let me back up. Medea actually has a lot more information than we do, but it's almost too much. We've tried to make it practical, but with some of those places where they send a tech to do the testing, a lot of those got in trouble with audits, because what happens is they go from doing 20 to 30 to doing 50 to 60. And then if you're not doing that many, they put the pressure on you. We did it for a little bit, but when we heard of a couple companies that got in trouble Lifeline, if you remember them, or BioLine, I think that's the name of the company. It is open season on that stuff. And I don't want an MA determining who gets tested. I want the physician, the clinician, and so we just stay away from that just because of the potential dangers of.
Can I
of
have
doing
your
it.
phone number? Or you can share your phone number after
You
permission
can go
from
through
Dr.
Jane. Jane or Ron can handle that. And then
Jane and
they'll
Ron, can
funnel.
you have my, can you share with us your phone number?
Sure,
If
my,
Dr.
my
William is
phone
okay
number,
with it,
this
I'm
is.
gonna steal it from you, Dr. William. I'll pay you 1,000 for him.
You always do. That's
This is,
We're gonna trade, we're gonna trade. I can give you
that's
something.
nothing new.
Doctor, if you want my phone number, this is Ron Riewold. I'll give you my cell number. It's
Okay,
407.
1 second. Let me just
Okay.
put it here. Let me make sure I'm recording it, okay?
Okay.
Okay, 1 second. Okay, what's the phone number, please?
407
407
808
808
2189.
2189. Okay, 407 808 2189. And your name is Ron, right?
Ron Riewold, Riewold.
Okay, Mr. Ron. Now, let me just give my 2 cents here. I think your products is the best among in the market because I know them all.
Yep.
And I do strongly recommend every doctor to have this system. I mean, Dr. William knows that I'm very promo for, because this system is like a stethoscope for the mainstream medicine. You know, they hear sounds of the heart and the bowel and all that.
Yep.
Well, this can feel the redox status, the oxidative stress, the inflammation, which most of integrative doctors, you know, what your job is to get this inflammation down, optimize the health. But how you can know that you're optimizing their health? You're giving 6 hormones, you're giving supplement, you're doing stem cells, but how you know that the inflammation is down and your free radicals, oxidative stress is down, is through measuring your endothelial function, ANS, because endothelial function and ANS, autonomic nervous system, and endothelial cells are the most sensitive tissue to the free radicals inflammation. And so when you test it and then you start to sex hormone and you're doing all your health optimization, and then you want to know if this works or not, after 3 months you test again, and if you can optimize the autonomic nervous system endothelial function test, that's mean what you have done, it's working. And if it's not, then there must be another leakage of free radicals, because it's like a tire with many holes. You need to look at the source of the free radicals that irritate the endothelial and autonomic nervous system. But I mean, congratulations for upgrading your product where the time is 7 minutes instead of 30 minutes. It was a hassle with 30 minutes. And also, I used the first one. You remember the first system that's being developed where you need to do yourself all the calculations, and it was
I remember that.
Remember that one? You know, you do all your calculations. There was not a computer to do the logarithm. We were doing
you had to have that
manually.
little you had that little we created, we thought we were so smart because we created a little cheat sheet to help doctors, and they never knew what they did with it. So it's like, okay, so but I do appreciate the comments and the feedback on that. And also I was going to ask you about post-COVID, the inflammation that has been left behind post-COVID. Oh my goodness, we still don't know the effects of it, but when it talks about that endothelial dysfunction, those type of things, it is, and you can very, very precisely see here in this metric here, when there's improvement, you can see that it's working. So I appreciate the comments, and I'm biased, but like I said, we did look at the Medea maybe 7 years ago. We were going to switch. We were looking at that, but that was before we opened up our clinic. So any other questions?
Let me add something, not for you, but Dr. William. Dr. William, if you want CME, I can give you CME. I have the CME. I can give everybody here a CME, but we need to go through certain steps and forms, and I can get your doctors here CME, no problem, because I need to have at least 30 per, I need to have more doctors. It's going to be difficult for us to do it separately. It's better to do it combined, because we need more doctors to get into the CME, for it will be reasonable to pay for it. You got my point?
All right. Well,
you want to go for it?
Yeah, well, send me the details.
I'll send you the details.
All right. Are you okay? Any other questions here? I'll get back to you in a minute, Dr. Alasa. Oh, no.
Joe, we had one question from Priscilla. So she wanted to know about how fast the practitioners are being reimbursed by insurance companies. Is it like a normal
It's the
reimbursement
same.
timeframe? Same.
Now,
Okay.
what we do though is John with a practitioner will say, okay, who's your main carrier? Like for instance, I think it's Aetna right now is wanting reports. And so instead of having them ask a question, he'll tell you, hey, if you're heavy Aetna, send the report along with it. And so if you bill it right and you bill it consistently, we find within 30 days or so it's being reimbursed, but it's no faster, no shorter than anything else. It's doing it right is what's going to prevent the delays or the questions. And that's where to speak to where we're different is we have the billing expertise to be able to help coach them through that.
Excellent. And then there's one other question that I had from Lisa. So with respect to the chiropractors, so some of them are teaming up with nurse practitioners. Does that make a
Perfect.
difference?
Yes, because if they're billing under their medical ID number, then they get reimbursed for that. So does anyone know who Dr. Sword is here in Atlanta, Georgia? She is south of the airport. She's a huge chiropractor that has an integrative practice, and she's got a couple locations, and she's got physicians in one of them. The other ones are nurse practitioners. They bill under their MPI, and the split they typically do is the clinician keeps the professional component, and the chiropractor keeps the technical component. Is the way they do that split.
Thank you.
Okay, anybody else? Comments, questions? Joe, that was a terrific presentation. Jane, we can't thank you enough for all your support.
You're welcome. Thank you.
Anybody, I am going to Miami tomorrow. I'm going to the AMMG conference, Age Management Medical Group at the Doral National Golf Club. I'll be speaking Thursday afternoon in the hormone section. And I'm doing all 1:30 to 4:30, I think they have me doing, and then Saturday morning also. Anybody's going to be there, you know, please.
I'm gonna be there, man. We're gonna have some dinner or lunch together.
All right.
Me and Dr. Joseph are gonna be there.
Okay.
But you said the Doral area, there's a good golf course there. I think I'd rather play golf
Yeah,
than go.
I've been afraid to ask how much a round of golf is there.
Put that into your fee. Put that into your rider.
I think it's got to be at least $1,000 for a round of
I'm
golf.
sure it is.
So,
Isn't that Tiger Woods or somebody? I forget.
yeah, he played there. Yeah. So, Dr. Quinn, you got anything for us tonight? You're muted.
Just real quickly, question. Joe, you went over all kinds of insurance pay and all that kind of stuff, and I
Yes,
must have
sir.
missed. Did you say anything about Medicare paying for this? Did
Yeah,
you?
Medicare is probably the easiest, most consistent because everyone follows the Medicare guidelines. This, by the way, even Medicaid reimburses. Medicaid, they'll reimburse us about $90 or so. So it's not, which doesn't make sense because if anyone needs the test, it's people that are on Medicaid. But
Yeah, exactly.
Medicare is your most consistent, easiest. I would say 99.9% of Medicare, excuse me, pays about $400. Your commercials are going to pay 20% more, 20% less.
Okay, and then maybe something along the lines of somebody comes in, like, you know, your buddy there, Bobby Test, comes in and then has all of these things and then is set up on a program or something to help them get better. Is there a frequency that will how would I put this, that insurance companies will pay for? They're not gonna pay for this like every month or every.
No, yeah. So that's a great question. So according to the LCD, any change of symptom, so any new symptom, any new diagnosis, any change of therapeutic intervention, any new medication, anytime there's a change, you're able to assess the progression or regression of that patient. If you're doing this once a month just to do once a month, it's not going to work. So statistically, this is what I tell everybody. We have found that about 50% of all the patients that meet clinical necessity are tested quarterly.
Mhm.
25% about twice a year, and the other 25% once a year. Typically, if you've got diabetes, if you've got shortness of breath, if you've got some type of chronic disease that's pretty far advanced, and you're going to the doctor quite a bit anyways. But this isn't for healthy 27-year-olds. This is for generally people that are over 50, 60, overweight, hypertensive, have some type of these signs and symptoms, or they got a diagnosis. But those are 50, 25, and 25 is about what it breaks down to, that we've seen. That's a great question.
Thank
I can help the doctors here in case one of the problems that you're gonna face is the, rejection from the Medicare from reimbursement because they ask you for medical necessity letter.
Yep.
And what you need to do is use the AI, artificial intelligence. Just put the case there and write down, a medical necessity for endothelial function ANS to the motor, and they will type it for you like a second. You don't need any. Try to use AI in your scribe and all that. With something I'm working on bringing on the table, scribe AI. So there's a company that's going to join us, and then I can help you with medical necessity and using AI, because this will save you like 60% of your time.
Yeah, we might, just to leverage on that. We're working on that right now. It may be available in the next 2 weeks, where we have the AI portal built into our CMAT, by
that's
the
a
way.
great plan. Okay, if you do that, that's a big shot. Yes. See, I'm helping you, right?
Yes, sir. No, we it's funny, and I don't bring it up because it was supposed to come out in January. It was supposed to come out in November. We worked on it, did some changes because we want to be compliant. But at our clinic, like we know Humana is terrible here in Georgia. I don't know why. So we always send this. We send the patient survey. We send the report. And ever since we started doing that, our adjudication rate it's phenomenal. But that's stuff that we learned and can help you guys with.
I like the way you did that thing that you had in the back from. It's just I like that.
Somebody's
Oh, I
got
thought somebody was asking a
you in
question.
the back here. Yeah, thanks. Okay.
Any other questions? Lakers don't tip off for another hour, so I'm from Los Angeles, so I've got nothing pressing but a Laker game tonight.
All right. Well, there's those of us that have said goodbye to the insurance companies. How many of your what percentage do you have that are just cash?
So to be transparent with you, from a sales standpoint for us, we just don't target chiropractors. They come to us organically through other chiropractors or through patients that go to them. I would say it's probably maybe 10%, but that's because we just don't, because again, it's something they have to, it is a device that's not 5,000. It's expensive. So we just don't target them, but it's about 10%. But again, if that chiropractor has a good following and they are progressive and they're more than just doing adjustments, car injuries, and they're really looking at holistically making a difference, those have done very well with the CMAT.
Well, the other thing is that the diagnostic test will help to provide more confidence for the patient to stick to the protocol of treatments. So maybe you want to provide a diagnosis for free, but then you tell, hey, I'm going to diagnose you here. This is the treatment that we're going to do. And if you follow it, we're going to diagnose you again. And the patient, when they see that there is an improvement, he will become more compliant and thankful. And that will add more kind of credibility to what you're doing. And it will help to promote even your clinic, because you say, hey, this doctor, I used to have my endothelial wacko. I mean, I'm almost going to get stroke. And now my endothelial is like a baby because of the treatment that he provided me. So it does add value to the treatment.
It really does. And I mean, again, when someone's going to a chiropractor, just the reality is they're in their mind, they're competing with a physician. And although they're both helping the same patient, but having something like this for a chiropractic situation really does bring that clinical side that some of your patients may be looking for or need. To be able to have something like this really does. We've seen it, but it's more reflective of the chiropractor than it is of the CMAT with the success of it. So I use it. I have a Corvette. When my wife drives it, she drives at the speed limit, has never used a power shifters in her life. when I get in that thing, you know, I maximize it, you know, so it's more reflective of you than of the CMAC.
Okay. Okay, anybody else got to have anything? So Jane, thank you so much. Ron Riewold, thank you so much.
Absolutely.
Great,
Happy to.
great presentation. Okay, I think you're hired.
I appreciate it, guys.
Okay.
And
Well, listen, I look forward to partnering, working with you
Thank
guys
you.
throughout. Ron and Jane are your contacts, and
Yeah.
mine is more on the presenting on the back end. If you guys decide to move forward, add this or share it with other potentials, that's where I jump in, but they'll be your main point of contact. But thank you, everybody. Enjoy the rest of your
Thank
night.
you.
Okay.
Thanks, folks. Appreciate it.
Thank you.
Good
And
night.
Thanks, Doc.
thank
I will
you.
be in touch with, we gonna call you, Ron.
Okay, you do that.
You're gonna get my call after this.
Okay, I'll be looking
Okay,
for
take
it.
care.
And
All right, bye-bye.
thank you and Ron and everybody and all your guests for being here. And
Thank you. Okay.
okay, so and with that, if anybody else has any comments or questions about anything, next week we're going to have Dr. Nario, who's preliminarily going to talk to us about cholesterol control without using medication. That's a preliminary, so I'm not sure I like that one. So we'll figure it out. So in the meantime, if anybody's going to be in Miami this weekend, please look us up, and we're excited to meet again. We have if you're in the Miami area, this is really a great conference. It's not like A4M. It's not overwhelming where there's 900 million people there. There, and the vendors are begging for your attention to pull you out into their booths from the aisle there. It's a very friendly group. I've been with them for many years now. I'm usually the last speaker, so one time I dedicated my talk to Johnny Castle, and anybody knows who Johnny Castle was. It was the character played by Patrick Swayze in Dirty Dancing, and his his white hot imperative was to he always did the last dance of the season, and for 7 years in a row I was always the last lecturer at AMMG. So I figured either they kept forgetting and they needed an extra hour, so they said, okay, hey, you get up there and do something, because they needed it for the CME credits, or they saved the best for last, one or the other. I couldn't figure out which one it was. So John, you got anything for us this week? You still here? Is John still on? Or is he going? Okay. And so with that, we'll see you next week. We have, like I said, we have Dr. Nario is going to be with us. A week after that, we're going to have Carol Peterson. She's going to pick up again on our exploration of the hormone, the world of hormones. Oh, and by the way, my first lecture on Saturday or Thursday afternoon is a basic men's hormone optimization. And though most of us are fairly familiar with it, because there's usually about half the group is our newbies, and they know nothing about it. But the beginning of my talk, instead of talking about testosterone, which you might think about, and so I'm going to just leave this for you and to give you something to chew on, is I'm going to be talking about progesterone evaluation and therapy for men. So hopefully you'll be, if you're there, you'll look up from your phones and make your dinner reservations without. So I'm just going to throw that out there. It'll be a little bit of a surprise, because I don't know if anybody here drawing progesterone levels and treating men with progesterone. So it'll be a little something to chew on. So, okay. So I hope to see you there if you're there. If not, we'll be back next week, same time, same station, as we always are. We'll have this up on our website, on our YouTube channel also. And Jane, thank you so much for all of your help and all of the speakers you've provided with us for us. It makes my job a lot easier because we have endless Tuesdays to fill. So
Thank you, Doc.
yeah,
Great group.
got anybody else? Send them our way.
Will
Okay,
do.
thank you, Dr. Alhassan,
Alrighty.
for being here as always, Dr. Quinn. Anybody who is new, thank you for for being with us. And the regulars, of course, you know, we appreciate you. Anybody has anything that want to present? Dr. Burgess, if you're there, I heard you did a bang up job with on Dr. Farshian's night. So we're happy to have you again. And Dr. Patel, I think it's time to have you also. And again, so with that, we'll say good night to everybody, and thank you all for being with us. And remember, we're featured now in the World Health Net Forum, worldhealthforum.net, worldhealthforum.net. You'll find us there every week also. Okay, so thank you all, and I'm going to say good night.